Hello, and welcome to the second episode of MedTable Talk, where we'll be discussing navigating the evidence, pathways for new and emerging BCMA therapies. I am your host, Melody Smith. I'm an assistant professor and physician scientist in the Bone Marrow Transplant and Cell Therapy Division at Stanford University School of Medicine, and I'm happy to be joined by my esteemed colleagues, Adrienne Phillips and Paula Rodríguez Otero. Adrienne, can you go ahead and introduce yourself to our audience?
Sure. Good morning, Melody, and the rest of our audience. My name is Adrienne Phillips. I'm an associate professor of clinical medicine at Weill Cornell Medicine at New York Presbyterian Hospital in New York City. I'm also in the bone marrow transplant and cellular therapy section.
And Paula, can you introduce yourself, please?
Hello, everyone. Very happy to be here with you again. I am Paula Rodríguez Otero. I am hematologist working at the University of Navarra in Pamplona, Spain.
So we are really happy in today's episode to pick up where we left off with our first episode and now talk about some drug resistance mechanisms, efficacy and safety of emerging BCMA-directed therapies, as well as strategies to promote timely initiation of care for underrepresented communities, increase clinical trial enrollment, and advocate for access to care. So remember, this is episode 2 of 3. So check out the previous episode and stay tuned to hear what other topics in relapsed refractory multiple myeloma we'll be discussing in episode 3. So to kick this conversation off, I think it's really important that we first talk about a patient. So we'll have a mini clinical case challenge that we'll discuss to really help to frame our discussion. So the patient here is a 65-year-old male with relapsed refractory multiple myeloma who's received 3 prior lines of therapy. This gentleman had no significant prior comorbidities, and he did receive prior bortezomib-induced therapy when he got triple therapy, and he developed some grade 2 peripheral neuropathy. In terms of his initial treatment, response, and follow-up, so at diagnosis, this patient had stage 3A disease, ISS2, and he had IgG lambda multiple myeloma with a normal karyotype, and it was also FISH negative. So for the first line of therapy, the patient received triple line therapy, 5 cycles of UCD, in which he had a very good partial response. The patient went on to receive an autologous stem cell transplant with maintenance. At disease progression, the patient was treated with Lindex for 12 cycles and then received daratumumab, bortezomib, dexamethasone for 5 cycles with a very good partial response. And then most recently, the patient went on to receive BCMA-targeted CAR T-cell therapies, which we talked about in depth in our last episode on a clinical trial. And for the CAR T-cell therapy bridging, he received Elopom-dex with a progressive disease after that. So, I'd like to open it up to my colleagues and talk about how would you classify what's happening with this patient? Paula?
Yeah, so I think that this is a classical case of a patient with relapsed myeloma that receive subsequent treatments and becomes resistant to each subsequent line because, as you all know very well, the treatment in myeloma is typically given until disease progression. So now we know this patient has been exposed and is already refractory to proteasome inhibitors, immunomodulatory agents, and also anti-CD38 monoclonal antibodies. So this is what we have called the triple class refractory, relapsed refractory myeloma patients. And we know retrospective data from the Mammoth study, and we also have a prospective observational study that is called the Locomotion study. And the 2 studies highlight that these patients that are exposed and become refractory to the 3 main classes of drug have a dismal outcome with a median progression-free survival that is shorter than 4 months and a median overall survival of less than 10 months. So this is the outcomes that we get in this highly resistant population, and this is why we need to incorporate novel agents, as we've discussed in the first episode. So we know that drug factors contributing to drug resistance are diverse, and to be honest, when you have a patient in front of you with resistant disease, you do not know exactly what is the mechanism of resistance in that particular patient. So we know that there are genetic alterations that confer resistance to particular drugs. We know that during the therapy, because the patients are continuously exposed, we know that there is clonal selection and there are new clones that emerge that have resistant mechanisms, whether because of genetic, epigenetic aberrations, or other factors. And for sure, tumor microenvironment, particularly, I would say, in the era of immunotherapies, are also important factors that do contribute to resistance to drugs.
Yeah, and I think it was really important, as you mentioned, that with increasing levels of resistance from triple to quad to penta, that the responses are overall worse, and there's different mechanisms for that resistance.
I think that, there are several, let's say, well-known mechanisms of resistance. So we know that when patients get exposed to immunomodulatory agents, that are drugs that are going to bind cereblon to make this is the mode of action of these drugs. We know that there are patients that become resistant because of mutations in the cereblon pathways that leads to absence or of action or substrate degradation. And also there are patients that do activate other signaling pathways that at the end of the day confer resistance to both lenalidomide and also to pomalidomide or thalidomide. We know that with proteasome inhibitors, there are also some known mechanisms of resistance, like genomic abnormalities of the proteasome subunits that led to impaired binding of the drugs, and also some other alterations on multi-drug proteins we know that are responsible of resistant to some chemotherapies. But in the era of the novel immunotherapies, particularly monoclonal antibodies, and as we discussed previously, CAR-Ts and bispecific antibodies, we know that the expression of the target in the tumor cells is also very relevant. And although, let's say, with BCMA targeted drugs, this is probably not the most frequent mechanism of resistance, there has been some reports of patients with genetic loss of the BCMA locus, leading to onset of BCMA negative clones, conferring resistance to the drugs. And the same has been also reported to CD38, for example, where we see a down expression of the target that may also be responsible in part of the resistance to the anti-CD38 monoclonal antibodies. But I think that there is still a lot to know, about the mechanism of resistance to all these drugs, and particularly to the novel therapies. And sometimes in the patient, it's very difficult to really dissect what is the real mechanism that is behind that failure of that particular combination.
So I think, it's really important when we're thinking about targeting, using a specific antigen to target therapy, for example, BCMA with multiple myeloma, the presence of that antigen is really relevant for ongoing utilization of that targeted therapy. Multiple myeloma is still uncurable, and there's an urgent need to develop new therapies for our patients, and recently received a lot of trial updates at the American Society of Hematology's annual meeting in 2022. Adrienne, how about we discuss some of the most interesting data thus far?
So, yeah, certainly last month in New Orleans, ASH 22 had a number of exciting updates related to BCMA targeted agents. So, talking about the erlantamab update, this was presented by Ballas and colleagues, and they specifically focused on the cohort A of the trial. So, this was a phase 2 open labeled, non randomized, multi-center study of erlantamab. And they found a very impressive overall response rate of 61%, with over 25%, a quarter of the patients having a complete response. They also reported data on MRD negativity, which was achieved in almost 91% of patients. And then in terms of toxicities, I think the toxicities were consistent with what we see with these bispecific antibodies in terms of hematologic toxicities. We saw neutropenia, anemia, thrombocytopenia. And then in terms of non-hematologic toxicities, we saw cytokine release syndrome. But importantly, they were able to mitigate some of these toxicities, particularly the CRS, by the step-up dosing of the erlantamab.
That's really exciting data. A bispecific antibody therapy that was also presented at ASH for the treatment of patients with relapsed refractory multiple myeloma. It was a first in human study, a phase 1/2 study, and the investigators reported on the severity of cytokine release syndrome and noted at the various dose levels that were found. In 200 milligram dose was the dose level that's going to be the recommended dose moving forward. So, of the patients who were treated, 252 patients who were treated with this drug on the study, 111 of the patients did experience cytokine release syndrome, and the median duration of that was about 15.4 hours following treatment. Alnuctamab, this is a result from a phase 1 study, a first in human study. So for this open label study, they were doing dose finding and evaluated patients at all doses, as well as patients who received less than 30 milligram dose, as well as those who received 30 milligram dose. They found that in all doses, there was an overall response rate of about 53%, but specifically at the 30 milligram dose, 65% of patients had an overall response rate, and 46% of those patients who had that overall response had a VGPR. So that's really encouraging data to note that among the 29 patients who did achieve a response, 16 of the 20 patients had evaluable MRD samples, and MRD negativity was noted in 80% of those patients. And so, along the same lines, in terms of the toxicity that we've previously touched on, some of the toxicity that was noted was cytokine release syndrome, as well as neutropenia and anemia across various grades. So, just briefly, phase 2 data for our fully human BCMA targeted CAR T cell therapy that was presented on Zevercell. So, this was really exciting data. We already have 2 approved CAR T cell products, as we've mentioned, but this is some exciting data about a target dose level that was infused of 150 million CAR T cells. And we found that this CAR T cell product delivered both deep and sustainable responses. It was well tolerated. So we looked at the duration of response. It was really nice, both data in terms of the duration of response as well as the progression-free survival. So again, really exciting data. So it'll be interesting to see how that data matures in the future. So, I think it's really exciting time in the treatment for relapsed refractory multiple myeloma. We've reviewed several BCMA targeted therapies that are new and emerging, and so more data to come based upon the ASH abstracts that we saw. But I do want to talk a little bit more in depth about the clinical trials that lead to these clinical approvals. So both the NCCN and ESMO guidelines support clinical trials for patients who are being treated with new and emerging therapies. And so as we look at the clinical trial participation, it's very important to understand the representation of patients who are enrolled on those clinical trials and some of the underlying disparities that may be a part of those clinical trials. Particularly, as we mentioned in our last episode, African American patients are highly represented, or in the U.S. at least, most commonly diagnosed with multiple myeloma. So it's really important that we think about the representation of the clinical trials and the patients who are being enrolled on these studies for these new and emerging therapeutics. So in order to delve a little bit more into the data in terms of the clinical trials and clinical trial representation, I'd like to welcome our guest for this episode, Dr. Saad Usmani. Dr. Usmani, can you briefly introduce yourself to our audience?
Thank you, Dr. Smith and my esteemed colleagues. I'm Saad Usmani. I'm the chief of the myeloma service at Memorial Sloan Kettering Cancer Center in New York. And, it's a privilege to be here.
Thank you. As we begin our sort of discussion about the representation of patients in clinical trials, I would like to touch on this ASH abstract from the Multiple Myeloma Cellular Therapy Consortium that analyzed the racial and ethnic differences in the safety, efficacy, and outcomes of patients treated with standard of care ide-cel. The investigators looked at 215 patients and looked at the ethnic and racial background, and we do see that there are disparities in terms of the percentage of patients enrolled, with the majority of patients that were analyzed, at least in this study, being white. And we can see that there were differences in the progression-free survival of the patients by race and ethnicity. patients who are white versus other. So, Dr. Usmani, I'd love to understand, a little bit more from your perspective. On our last episode, we just briefly touched on the lack of representation in clinical trials for patients with multiple myeloma, especially underserved populations. And so, what is the value of clinical trials from your perspective, especially for patients with relapse refractory multiple myeloma?
Thank you, Dr. Smith. I'll start by saying that, there is a clear recognition now within the myeloma research community that this is an issue. And, there have been several measures to actually address it. I grew up, as a junior investigator in a program, in a very busy myeloma program, where we had a culture of high clinical trial enrollment. I think more than 60% of the patients coming to see us would go on one or the other clinical trial. But the minority representation was less than 5%. So when I had the opportunity of moving and building a program, this is something that one had to address head on. I think there are several important aspects to it. Certainly both implicit and explicit biases. That one has to overcome. There are perceptions both on the patients as well as physician side that have to be overcome to improve clinical trial enrollment. But then, systematically, you have to, go a step further and see if you can introduce, certain benchmarks into clinical trials of enrolling minority patients. For our Black myeloma patients in the U.S., they make up, over 20% of patients being diagnosed with myeloma. Yet, if you look at historic clinical trial enrollment, on even cooperative group trials, which are supposed to be catered to the community outreach, we see about 3% enrollment. So I think a lot of these issues have been recognized, and we actually have clinical trials that are looking at increasing enrollments, introducing champions at each site or regional site to include clinical trial discussions with patients, and then having patient advocates actually improve health literacy and importance of clinical trials out in the communities. I think all of those things are very important, going into improving outcomes for our patients.
If I may ask, is this because there is a cultural barrier? Is this because there is a financial problem? Or is because the inclusion and exclusion criteria does not fit the same in the different populations? Because it may be because also that you get I don't know, a Hispanic patient, but then you feel at the end of the day that there are some limitations based on the inclusion criteria because I don't know, the neutrophil count is lower, and then so is it this because there is a cultural, financial, or is because of the design of the trial that make it difficult to patients to get in?
I would say it's all of the above. There have been studies looking at, socioeconomic status and outcomes in myeloma, and there is certainly a disparity there, towards minorities. So patients get diagnosed with higher burden of disease. They might have more end organ damage, and when you have those kind of presentations, the exclusion criteria is like, creatinine clearance, or degree of anemia or white blood cell count becomes a problem. And so I think, patients get, excluded from clinical trials because of those reasons as well. But, one can mitigate by being a little bit more generous in those inclusion and exclusion criteria to include patients. And, that kind of push has to come from us. And more recently, that's what we have been doing as myeloma research community, is pushing back on some of those inclusion exclusion criteria that do not make intuitive sense, because when the drugs and regimens get approved, we're using them for all patients.
Exactly.
So I think you raise a very important point. I think all of those things are kind of interlinked as well.
I'd like to comment on that, just looking at it from the provider angle too, because certainly there's distrust in the system, perhaps among some patients with clinical trials. But I think us as providers also have to recognize our implicit bias. And I'm sure there are providers that, looking at their patient in their mind, think that this would not be a good clinical trial patient, and it's not even offered to
Yeah,
them. So I think the burden is not, on the patient. It's really like, what can we as a provider do to
absolutely.
bring these trials into the community? We're talking about BCMA targeted therapies that are such a logistical, it's hard to get patients to manufacture T cells and to monitor for toxicities. Saad, you and I are across the street in New York City, and we're at these great academic facilities. But how do we get these treatments into Staten Island or Brooklyn, or thinking more nationally in the US, into the Midwest, where maybe they don't have a cellular therapy center, or, five cellular therapy centers within 5 miles, and the next available center is 100 miles away. So I think there are a lot of challenges here that we need to address.
But also, I think it's also important because maybe the safety profile it may be different.
Right. Yeah, I was just going to touch on that. The ASH abstract that we just briefly mentioned showed differences in progression free survival based upon ethnicity. But, there could be some underlying differences by ethnic group. The other thing that could potentially be at play is that patients, due to their delayed referral, and higher lines of therapy are doing worse because we're just waiting longer for some minority patients to receive the therapy. So I do think that there's, so many factors at play that could be impacting the responses that we're seeing, but also that are limiting our ability to really make conclusions about the data that we're seeing from these clinical studies. And, Saad, have you found any approaches that have been really effective to go out to the community and bring patients to the center in a more rapid clip, or to work more closely with community providers to refer them and not wait for patients to come and maybe not benefit as greatly from these newer therapies?
It boils down to communication and outreach, and this is something that I was able to do. I mean, when I started a new program in North Carolina, I went from a program where people came to you, patients came to you, physicians called you up to get patients in. And in North Carolina it was the opposite. I had to build that trust with the community. I had to build that trust with the local oncologists who were providing great care to patients, but did not have access to trials or transplant and cellular therapy procedures.
I definitely agree with you because, one thing that comes to mind as we're talking about these new therapies, these novel therapies for patients, is that if we as providers, as clinicians, as the healthcare system, don't work to bridge this divide, whether it's communication or misconceptions with our patients, the disparities are just going to become compounded.
I think the only point that we have not touched upon is actually encouraging, physicians and physician leaders from minorities to join, the mission in caring for patients with heme malignancies. I think that's something that, many institutions are now recognizing and trying to do. But I think that's a very important, part of how we break down these barriers and improve communication with the community at large, and improve outcomes for patients regardless of where they come from.
Thank you. No, thanks for sharing that. And I would like to highlight to our audience that there are resources available for patients and caregivers through organizations such as the Leukemia and Lymphoma Society, as well as the Myeloma Research Foundation, as to how we can, help to educate patients and their caregivers to be able to be knowledgeable about these therapies, ask their physicians about these therapies, and identify centers where they can get this treatment if they have myeloma that's relapsed and refractory following multiple prior lines of therapy. So it's really important to know that there are resources out there for you to also educate yourself. So, Dr. Usmani, thank you so much for your time. I really appreciate that this has been a robust discussion, and we really do appreciate your perspective and insight as to how we can troubleshoot and mitigate some of these disparities that we're currently seeing in clinical trials.
Thank you so much.
As we kind of go to sort of recap some of the things that we've discussed, I would like to give us an opportunity to hear from each of our colleagues in terms of some of the take home messages or really important things that we want you to be left with as we conclude this discussion. So, Paula, what would you say that you would like to see in a perfect world relating to the new and emerging therapies as well as to representation within clinical trials?
In a perfect world, I would like to see novel agents evaluated in all patients, let's say, or in the wider populations possible to get a better understanding of the real efficacy and the safety. And more importantly, I want drugs to be available for any patient in need, because this is the beauty of science, that to make, science counts for patients and drugs available for patients. And I think that this is the most important part of our work. And what about you, Adrienne?
So in my perfect world, these are highly specific therapies that right now are benefiting a select few. So as others have said, I would like to have access to all. And then they are not without their toxicities. So I think in the perfect world, we need to just know how to use these therapies smarter. There was a study that did the step-up dosing, find the correct dose, find the correct mitigation strategy. So hopefully these therapies can be given in an outpatient setting, in a rural or community setting. That's also how I think we could deliver these therapies more effectively to patients who need them.
And as I think about a perfect world, all of us as healthcare providers who take care of patients who are receiving these therapies for relapsed refractory multiple myeloma do have a desire to see less healthcare disparities, particularly as it relates to clinical trials. I would like to see more guidance from funding and regulatory organizations to help put a little bit more of a framework as to the enrollment on clinical trials, because as was alluded to earlier, sometimes until those guidelines are handed down, the prioritization of representation in clinical trials, although it's at the top of mind, may not be fully actualized. So I think some guidance or maybe even regulations around representation in clinical trials may be beneficial in the future. I just would like to thank everyone, my colleagues, as well as our guest, Dr. Usmani, for participating in today's MedTable Talk. There are several resources that you can download from the activities website. Please join us for our final episode, our third episode of 3, where we'll discuss creating patient-centered approaches to optimal care, best practices for utilizing BCMA-targeted therapy. We hope you learned a lot. To get credit for this activity, complete the post-test and evaluation.